Respected Chairperson, members of the faculty and students, I'll be presenting clinical profile and visual outcome of pellet-related ocular injuries. This is one of the unique studies in the world where we have seen 1066 injuries over a period of 1.5 years. Ocular trauma is leading cause of monocular blindness. Ocular shotgun injuries have been seen, but limited data is present all over the world. The experimental studies done by DMNO concluded that the critical velocity for penetrating of the human skin by an air gun pellet was between 38 and 70 millimeters per second, and this explains the ability of the shotgun pellet to perforate. The eyes being exposed to the surface are susceptible to more injuries than any other tissue. The aims of the study was to see the clinical profile of pellet gun related ocular injuries and determine the visual acuity and visual outcome in patients with pellet gun ocular injuries. Material investments, it was a prospective observational study done in Ophthalmology Department, Medical College, Srinagar from July 2016 to 2018, where we had 1,066 patients of 664 eyes with 643 patients. The follow-up was the patients were done for 1, 3, and 6 months with best corrected visual acuity, intraocular pressure measurement, slit lamp examination, and OCT fundus examination, FFA, wherever required. The inclusion criteria was all age groups, pellet gun injuries with an informed consent, and those patients who would follow up for a period of 6 months. Exclusion criteria was if at all there was any previous intervention, any other surgery like cataract, glaucoma, or other surgery is done, or any other institution where it was previously operated. We used to take a history, visual acuity, slit lamp examination, fundus, pupillary reflex, intraocular pressure, and non-contact tonometry. And we divided them into open globe and closed globe. Open globe injuries were seen with those who had less than 5 millimeters of intraocular pressure, shallow AC, afferent pupillary defect, pupil peaking, dense clear subconjunctival hemorrhage, obvious laceration, and a CT documented foreign body. They were put on observation under an microscope and exploration at the same time, and a primary repair instantly. Then the classification was done as per Ocular Trauma Society classification, and we have seen that various variables were seen in this study. The age distribution was seen between 22 to 0.5 years was the mean age group. The gender was, they were mostly 98.6% were males, while laterally it was bilateral in 3%, left eye 49%, and right eye 48%. This is one of the patients who had multiple injuries on the back, face, and all over the body, and the other girl who had over the face with bilateral perforation. This kid had both eyes perforation. Type of injuries was open globe as well as a closed globe. The open globe constituted about 42.5% of the patients who had a better visual outcome, and a closed globe injury that had 93.9% had a closed globe injury with a better outcome. The better outcome was graded depending upon the presentation and depending upon the type of injury. You can see in this patient, the patient had a scleral wound, uveal prolapse, and a vitreous prolapse, and a corneal scleral tear with iris prolapse and vitreous loss. This patient had hyphema, corneal tear within pellet in the anterior chamber. Depending on OTC closed globe, we devised their visual outcome and found that those patients who had a perforating injury had a poor visual outcome. In this picture, you can see a subconjunctival pellet, while in the other case, you can see the subconjunctival hemorrhage with hyphema. Most of the patients with open globe presented with hemorrhage in 83.4% of patients, and on the and perforating injury in 54.9% patients, while they had macular as well as juxtamacular perforations in 21% and 35%. Those patients who had closed globe injury, the presentation was in 58.2%, that hyphema was the most common presentation. In this picture, you can see the B scan of a patient with pellet injury who had total RD with a vitreous hemorrhage. A CT scan showing a perforating injury with emphysema, and a post-operative OCT showing a macular hole, and in this patient a macular ischemia and scarring on FFA. Mostly they don't have a good prognosis depending upon the type of the injury. This patient, you can see an intumescent subluxated lens with an anterior dislocation. A vitreous hemorrhage which is resolving, while this patient had an exit wound from the optic nerve. Depending upon the surgeries and the prognostic sequence, it was seen that the earlier you intervene, the better prognostic was seen. Anatomical outcome was better in 98% of patients, while 81 patients had thysis bulbi and 103 had proliferative vitreoretinopathy. These are some bad pictures of the patient, and in the upper patient, here you can see that the exit wound is through the optic nerve, so the vision was very less, and here the macula was spared. There is a scar along the inferior vascular arcade, but at the same time there is little puckering of the macula resulting in poor vision. And this patient, you can see that there is thysis bulbi. This patient had giant tear, SFIOL was done, and the same patient with total PVD. The small video wherein we are doing the pars plana lensectomy with vitrectomy. We remove the lens material from the anterior chamber using a cutter. Vitrectomy with 25 gauge can we induce the PVD, we isolate this pellet and just remove the pellet from 3.5 millimeter from the pars plana. After that part, you can see that this forceps was devised, innovated for these pellet injuries. The wound was extended and the pellet was removed. And the wound was stitched with 6-0 Vicryl and complete vitrectomy was done. Thank you.
Thank you, Dr. Tariq. We have learned a lot about this and the injuries being brought on to pellet injuries. My just question was that lot of macula and the posterior pole exit wound you have shown. What was the distance of the sort of gun? Because they are tending to diverge out. They may be point blank.
Normally it doesn't come in point blank, but since the velocity is more, and eye being a very soft tissue, the penetration is mostly through the posterior pole. And most of them, 70% had a macular scar or an exit somewhere in and around the optic nerve. As a result, that the post-operative visual acuity improvement was not that significant even after 2 or 3 vitrectomies. When the macula is scarred, the central vision is poor.
So the question was that if the anterior entry wound is there and the exit wound is close to the disc, normally all these pellets diverge. And what I mean to say is these injuries were very close to you. That is why they came onto the cornea or at least anterior sclera and went close to the macula, or there were some other reasons.
There was no reason for why the macula was injured, but mostly it's seen that once you look at the gun, it hits like in the posterior pole only, because most of the human tendency is to focus at some target, and the target comes directly or either to the posterior pole or some way around it. And but these are very bad injuries, and the visual outcome has not been that good overall. We have achieved the anatomical success, but the physiological success has not been that good. Thank you, sir.
Thank you. Now we request Dr. Sunil More.